So first of all, thank you so much for attending the 10th and final panel as part of our Dissemination and Implementation Science Speakers Series. I'm going to briefly introduce myself and then the broader goal of the speaker series and then our esteemed panelists. So as many of you may know, I'm Brianna Last. I'm an assistant professor in the clinical area of the psychology department at Stony Brook University. And the Dissemination and Implementation Science Training Series is part of a project funded and supported by the Academy of Psychological Clinical Science. And the overall goal of this project is to strengthen dissemination and implementation science training across clinical psychological science training programs. As population mental health challenges have become more pressing across the country and around the world, there is a real need to ensure that people can easily access high-quality mental health services. The question of how to meet this need is one that dissemination and implementation scientists have really tried to answer. And the field has developed unique methods, theoretical frameworks, and models that can help move the needle on population mental health. But training in dissemination and implementation science is not widely available in clinical psychological doctoral programs. So our hope was by making the speaker series free and virtual, that it can support everyone who's interested in learning about D&I. So today's panel is Policy, Dissemination, and Implementation Science, and it features our esteemed panelists, Doctors Beth McGinty, Erica Crabble, and Jonathan Purtle. Each speaker has extensive experience with and expertise on this topic, and I'm so delighted for you all to hear about their important contributions. So now I'm going to just briefly introduce the speakers and then let them take it away. So Dr. Beth McGinty is the Livingston Farrand Professor of Public Health and Chief of the Division of Health Policy and Economics at Weill Cornell Medical College. She conducts research focused on how health policies affect populations with complex health and social needs, including people experiencing mental illness, substance use disorders, chronic pain, and others. Dr. McGinty's work is characterized by integrating approaches from the fields of public policy, health economics, and implementation science to understand how policies affect population health. And then finally, Dr. Jonathan Purtle is Associate Professor of Public Health Policy and Management and Director of Policy Research at NYU's Global Center for Implementation Science. His work examines how the implementation of policies on the books can be improved in practice, how research evidence can be most effectively communicated to policymakers and is used in policymaking processes, and how social and political contexts affect mental health policymaking and policy implementation. Dr. Purtle also studies population-based approaches to mental health and suicide prevention. So each panelist is going to speak for about 15 to 20 minutes, and then we'll have a question and answer period. I'll begin the question and answer period with some of my own questions just to get it started before opening it up to the audience. So we just ask that you hold your questions until the very end. And should you experience any difficulties with technology, like if you get kind of hopped off Zoom and you have any challenges, you can email dissemination.implementation@gmail.com. We'll be monitoring that email address, or you can try to chat with Madeline and Laura if you all can wave your hands to see who they are. And finally, if you would like to view this presentation with closed captions, if that would be more accessible for you, you can click Show Captions on the bottom bar of your Zoom screen. Okay, that's all for the preamble. Without further ado, let's begin with our first panelist. So Dr. McGinty, do you want to take it away?
Absolutely. Thanks so much, Brianna. Really nice to see everybody. Thanks so much for having me. Let me share my slides here. Okay, are you seeing the correct version? Yes, thumbs up. All right. So I am going to kick us off this afternoon with an introduction to policy implementation research and a mixed methods example from my own work, with the idea that perhaps it's easiest to start to get your head around what policy implementation research looks like by seeing an example of it. I will, however, start a little bit definitional in a way that isn't even on my slide. So I'm just going to say it while we're on the title slide here. We are talking about policy dissemination and implementation research in this session. I am focusing specifically on policy implementation research. So what is the difference? The difference at a high level, you will hear more about this from Jonathan and Erica, is that policy implementation research is studying how policies that are on the books, you heard Jonathan just say this, policies that have been enacted and are in existence in the world, how those are implemented in practice. Policy dissemination research is all about how we get evidence-based policies adopted and on the books. So that's the distinction, and I am in the implementation domain. So let's jump in. So I'm going to start by giving you a bit of motivation for studying health policy implementation, sort of how I came at this in my career. I'm trained as a public policy researcher in my PhD program. I came to implementation science as an early career researcher, and so you'll get a little bit of that lens on my first few slides. And then I'll give you this research highlight and just a few concluding thoughts. So why do we care about policy implementation? In a nutshell, why I care about it is that we put a lot of policies on the books and then they don't achieve their goals. And that is a waste of many things: resources, political capital, time. And these are policy implementation failures, right? We have a lot of policies that we think are evidence-based, or perhaps at least evidence-informed. Evidence is never the only thing that goes into policymaking, that don't achieve their goals due to implementation challenges. And so this ultimately results in a lot of unrealized opportunities to improve patient and population health. So as promised, here's how I came at policy implementation research. So as someone trained in public policy, I was trained to do largely quantitative research using big data and non-experimental methods for causal inference to evaluate how policies impact outcomes. And in this framework, implementation was a black box, right? We're using things like difference and differences models, which is just a kind of regression model to evaluate the impact of policy. And the policy is a 1 or a 0. You have it or you don't. A state has it or it doesn't. A health system has it or it doesn't. And then you're looking at outcomes. And implementation is sort of nowhere in there. But in reality, implementation matters a lot and is determining whether and how the policy influences outcomes. And that always seemed problematic to me. So, as I said, I sought out some training in implementation science in my early career, which was both super useful and at first totally mystifying, because it was like, as a policy person, we were speaking entirely different languages, which we were. And policy and implementation science at the time, this is like, over a decade ago at this point, policy was this sort of like hand-wavy contextual factor in implementation science. Like, it wasn't really in any of the conceptual frameworks. People weren't thinking about it at all. What they were thinking about was evidence-based practices, which were clinical practices or health behavior programs. And implementation science was thinking about what are the provider and organization level implementation strategies, like training or facilitation or audit and feedback, that will improve adoption and implementation and fidelity, which are all implementation outcomes of evidence-based practices. And policy, like I said, was this sort of like vague, like, oh yeah, that's sort of shaping what's going on here, but we're not measuring it or thinking about it effectively. And so I got interested in thinking, okay, how do we sort of bring these two fields together a bit more to understand what I think and what the decision makers I work with think tell me that they need to know, which is, what implementation structures and strategies need to be in place for health policy to achieve its goal. When I talk to health policy makers and say, look, we saw that this policy like had really beneficial outcomes in Texas, they're like, great, how? Like, why? Like, what do we have to do to implement that policy in our jurisdiction? And we often can't answer that question in the policy. So I have sort of ever since then been really interested in bridging these fields and thinking about can we unpack how policy implementation is influencing the outcomes of interest and potentially some like unintended consequences that were not the outcomes of interest as well. Okay. So the final sort of introductory piece that I'll give here before I jump into an example is Heather Bullock and colleagues' policy implementation process model, which I find very useful and draw upon a lot in my own work, and is sort of a more thoughtful and comprehensive version of like this simple little 3-box model that I have on my bridge slide here. So let me unpack a couple of key components that I think it's worth noting about this model. So first of all, I think a big contribution of the Bullock model is to really clearly delineate the fact that policies are not monoliths. They're packages of rules, usually. Sometimes you get a really simple policy that is sort of one, now you must do X kind of rule. But usually what we call a policy is a piece of legislation or like a 50-page regulation that is in reality a whole package of interrelated rules. Policies are just rules. And so that is an explicit component of this model. I think another really nice aspect of this model is that it acknowledges that policies exist in an ecology. Like you have a policy of focus, like I am interested in state laws that cap opioid prescription dose and duration. You're going to see this in an example. But there's a whole bunch of other policies out there that are related to those laws. Other policies about opioid prescribing, other policies about chronic pain treatment in general. And so in this model, you see policy level A, policy can be both context and sort of the thing of interest, the evidence-based practice, or maybe it's not evidence-based, but it is still the thing of interest. And so the fact that there are sort of levels and an ecology and then this package aspect I find very useful here. And then the implementation process itself, once you've sort of understood what the policy or policy package is and how it is situated within the policy context, you have implementing organizations, which might be one type of organization. It might be a whole bunch of different types of organizations, depending upon the policy. You have street level bureaucrats, which what Bullock means by that is sort of the frontline implementers within those organizations who often aren't conceptualized as policy decision makers, right? The policy is already on the books. They are, however, policy implementation decision makers who are making decisions with their feet in terms of whether and how they ultimately implement a rule. And then you have recipients or sort of the target audience of the policy who the policy is meant to perhaps confer benefits upon or otherwise change behaviors. And then, and only then, after sort of all of those steps, do you get to either implementation or health outcomes. All right. So let me give you an example that will hopefully put a little bit of shape on some of these ideas. I don't intend for this example to be like, here is the prototype for what policy implementation research looks like. There are many, many possible designs and approaches for policy implementation research. This is one illustrative example. I do think it's a useful illustrative example in that it is mixed methods, and much policy implementation research is mixed methods, where you have some quantitative, often ideally causal work to evaluate the impact of the policy on outcomes alongside some descriptive, which might be qualitative, it might be survey, it might be descriptive, quantitative work to try to characterize implementation processes. And you're sort of mixing those together. So in this example, we were focused on studying state opioid prescribing laws. So in response to, in particular, the early phase of the opioid overdose crisis in the United States, which was driven by prescription opioids, states put a bunch of different kinds of laws in place designed to curb overprescribing and hopefully overdose rates. And we wanted to understand how these laws impact outcomes, but also how their implementation might influence heterogeneity of policy effects across states, right? Is it possible that a law has one kind of effect on outcomes in Texas and a different kind in Nevada? So there were 4 types of laws that we looked at. You don't need to really understand all of the weeds of these laws in order to get the gist of this talk, but I'll give you just a little bit of context. So we looked at opioid prescribing cap laws. These are state laws that limit the duration or dosage of prescription opioids. Often they apply to certain categories of prescriptions or categories of providers, like opioid prescriptions in the emergency department cannot have a duration longer than 5 days, something like that. Pill mill laws require strict oversight and regulation of pain management clinics. This was in response to a pill mill phenomena that happened particularly in some southern states like Florida and Tennessee, where there were pain management clinics that were essentially run out of storefronts. They were non-medical settings. They were often offering prescriptions in exchange for cash with no medical exam required. And so these laws are designed to sort of crack down on that phenomenon. Mandatory prescription drug monitoring query laws. These are laws that require prescribers of opioids and other controlled substances to query the PDMP database, which is just a state database of controlled substance prescriptions, before prescribing an opioid to a patient, to see perhaps if that person has multiple other opioid prescriptions or a benzodiazepine or other prescription that with a co-occurring opioid prescription will increase risk of overdose. And then a different flavor of PDMP law, mandatory PDMP enrollment laws, require prescribers to gain access to the PDMP, but doesn't require them to actually check it. So basically they have to have a username and password, but it's not quite so prescriptive in terms of what providers have to do. So we wanted to understand at the time these laws were implemented, whether the downward trend in opioid prescribing that we had started to observe across the country already by like the mid-2010s was being caused by these laws. And when we did this study, there were already some studies out there, but the results were very mixed. And there were a bunch of methodological challenges that we tried to address. And we wanted ultimately to answer these questions, because if these laws reduced high-risk opioid prescribing, we might want to enact them in other states. But we also wanted to understand in this context where states are like throwing spaghetti at the wall, and some states put all of these laws in place, right? Some states like picked one out of a hat and said, we'll try that one. Whether there might have been downsides to some of these that would help states use sort of their limited policy and political capital to pick the most effective laws. We were also studying this in the context of this narrative around opioid prescribing and chronic pain, which was this idea that these kinds of laws were having adverse consequences on people with chronic pain who had been using opioids to manage their pain, but now couldn't access those opioids as a result of sort of the pendulum swinging too far in the other direction. And so part of what we did was look at the impacts of these laws among folks with chronic. This is published, this was one of the pre-reads, was this Annals of Internal Medicine paper, which is sort of the main quantitative results paper. The primary implementation and enforcement paper is in drug and alcohol dependence. And there's also a protocol in implementation science, which might actually be the most useful paper. I maybe should have given you that one as a pre-read because it has like all of the pieces of the implementation and the outcomes in it. Okay, so what did this study look like? So we designed a quantitative component that was designed to address this problem, which is frequent in the policy research context, of the spaghetti effect that I just alluded to, where a bunch of states put multiple opioid prescribing laws in place at the same time. When they put multiple in place at the same time, or like within months of each other, you cannot disentangle the effects of which law had which impact, right? And so that doesn't help in terms of producing evidence for decision makers to know which one of these might be most effective for them to check. So we used a design-based approach where we identified 13 states that had a single one of those laws. Each of those states, we designed a unique comparison group and a unique study periods for 2 years before and 2 years after that state laws. We were looking at commercially insured adults with chronic non-cancer pain using insurance claims data. We had a whole battery of measures around prescription opioid and guideline concordant non-opioid alternative pain treatments to try to understand, was there an unintended consequence here where folks with chronic pain might just be getting less treatment in general, like opioids are harder to get, but they don't get anything else instead. And we used an analytic approach that I'm just not going to get in the weeds on, called an augmented synthetic control approach, which basically weights the state with the policy to look really similar to the state without the policy and does sort of a difference in differences pre-post comparison in changes in outcomes over time. And then we did a qualitative study where we implemented 117 state-level implementation leaders on medical boards or state health agencies or health systems who are implementing these prescribing laws in those same 13 states to try to understand implementation strategies, barriers, and facilitators, and did a hybrid inductive deductive coding approach to understand what those might look like. So in a nutshell, what did we find here? So we expected, remember, part of my motivation was like, oh, there might be heterogeneity in effect across states. Like we might see a prescribing cap law have really big reductions in opioid prescribing in Texas and no changes in opioid prescribing in Vermont, and maybe implementation will explain those differences. So that did not pan out in that we found no effects across any states of any of these laws on any of our outcomes. This is like the most null study I have ever done in my whole life. The good thing about null findings in policy research is like the null findings are still really interesting and valuable. So these graphs just show you in the context of opioid prescribing cap and pill mill laws that we really didn't see changes in the percentage point difference in the proportion of patients receiving opioid prescriptions attributable to those kinds of laws. You see the point estimates are like hovering on 0, right? We essentially had near 0 changes attributable to laws. Same deal for the PDMP query laws. And same deal for all of our other outcomes, like teeny tiny, less than 1 percentage point change in the proportion of commercially insured adults and those with chronic pain receiving any opioid prescription, less than 2 percentage point change in clinical guideline concordant non-opioid treatments attributable to those laws. So we also didn't see evidence of this like unintended consequences narrative for pain patients that I showed you that headline of a couple slides back. On the qualitative side, we had really interesting findings in that we identified some common and interrelated implementation barriers across all 13 states, which I think is one plausible explanation for why we had consistent null findings across states. All of these laws had a lot of exemptions, which meant they didn't have a lot of teeth in reality. They were really complex, which made it hard for implementers to put them into practice. And then there was just lack of health IT capacity to actually figure out if anyone was adhering to these laws and to enforce adherence if not. So, in conclusion, the point of that was to give you one example of how we, in a relatively straightforward, sort of simple design, married qualitative and quantitative research to study policy implementation. This was a pretty basic concurrent embedded design where we did the quantitative and the qualitative concurrently. The quantitative was primary, and we considered the qualitative to be sort of embedded, and we used it to refine our models and to interpret our results. You can imagine many more sort of more multifaceted mixed methods designs to study policy implementation. This is a relatively straightforward one. So in conclusion, I'll just end with what I think of as the 3 C's for policy implementation research, and what I think about a lot as I try to think how to advance my agenda in this area. So the first is complexity. Policy is kind of by definition top down, right? Like legislators, Congress, health system leaders make these policies and they impose them on systems and on people. And that approach, problematically, is really poorly suited for complex systems. These top-down policies spawn all kinds of sort of unanticipated effects. And so I think we really need to be thinking from a more bottom-up, and this gets to the 3rd C, co-produced perspective, where we are developing and testing policies bottom-up within systems. And then context, policy implementation needs to be tailored to context, and that context includes other policies beyond the one that you're studying. And we talk about all of those. I flagged it here in this Lancet Psychiatry Commission that we did last year. And I will stop there, a couple minutes over. Thanks.
Amazing. Thank you so much, Beth.
Everybody see everything? Yeah, looks good. All right, cool. Well, thank you, Dr. Last, for organizing this. I love learning from my esteemed colleagues. Yeah, so there's going to be some overlap, but I think in synergistic ways to drive home some key points and a lot of similarities in how we all approach this, and like some subtle differences too, which I think is great. So I'm going to focus on, I guess I'm going to give a little bit of background of context first. So I also got an implementation science as an early career person about 10 years ago. My training is in public health. I'm a DRPH, and I was always really interested in kind of the misalignment between policies on the books and evidence, epidemiologic evidence, mainly about mental health and substance use issues, and what might work from a policy perspective. And I kind of stumbled across implementation science. I had not heard of implementation science in my doctoral training. And it was this wonderful kind of light bulb moment. Great, there's an opportunity here for me to kind of couch these questions that I'm really passionate about within this new and emerging field. And I get into the field and I find that, by and large, this field is really focused on implementation problems that are clinical in nature. Super important, but not what I'm into. So what I'm going to present today is kind of like where I ended up after a journey of trying to figure out different ways that we can think about policy and implementation science research. And again, there'll be some great overlap with Dr. McGinty and Crable's presentations. So what I'm going to present on is in these 2 pieces here, 4 basic ways to think about policy and implementation science, an intentionally very short article, very simplified, and then the longer form is in this book chapter here. If you want it and can't find it online, shoot me an email and I will send it to you. All right, so I'm going to talk about 4 different ways we can think about policy and implementation science. And we can think about these 4 ways across this continuum, these 3 different time points, if you will. So we have policy making, of course, the social and political and administrative processes through which ideas really become codified and laws and regulations. Then we have the policies themselves on the books that are written down. We can look at those. And then we have the implementation of those policies, which is a whole other can of worms, if you will. So these 4 ways, so I'm going to just define them and then give examples for the rest of my talk. So 1, we can think about policy as a strategy to use, or policy as context to understand. And I think in this middle rectangle here, I think there's a real role for policy in kind of clinically focused implementation science research. So you might, your implementation science questions really might be focused on delivery of evidence-based practices in clinical and programmatic settings. You're not a policy person, but you recognize policy is a contextual factor that it doesn't make sense to ignore. It's definitely relevant. Or thinking about how policy can be used as a strategy to directly influence barriers and facilitators to delivery of the evidence-based intervention. Over here, we can really focus on the policy itself. So the policy on the books, we want to understand how to improve the implementation of that policy to maximize public health benefits. And then over here, we have what we call policy is something to adopt. Both Beth and Erica spoke to this, how we better disseminate research evidence to policymakers to get policies on the books that are aligned with what is most promising from a public health perspective. So I'm going to walk through each of these, give some brief definitions and some examples, mainly from my work. There's a lot of other great examples out there, but pulling from my own work because I know it best. So policy is a strategy to use. So here, thinking about how we can use policy to directly address barriers and activate facilitators to implementation of a clinical or programmatic intervention. So that's the thing, this clinical thing, we're thinking about how we can use policy to our advantage. The big caveat here is we can't just wave magic wands and use policies to do whatever we want, right? It requires political will, commitment from policymakers. Sometimes it's not feasible at all. Policy is often challenging and slow to change, but also it really happens really quickly sometimes, right? Like the stars align, there's a policy window, and then there was this moment for policy change. So I'm going to give an example from our work. This is an R01 funded by NIMH, which is focused on implementation of the 988 Suicide and Crisis Lifeline. So here, the thing, kind of the evidence-based intervention is the service that you get when you dial 988, right? So it's like supportive listening, suicide risk assessment, and then next steps according to your risk level. And that could be emergency response. More often, it is referral to services, things like that, right? So that's the thing. So 988 was created by federal law. The whole point of the federal law that created 988 was to increase demand for services. When you increase demand, you have to increase capacity, right? You have to hire people to meet this increased demand. And to increase capacity, you need money. But the federal law doesn't provide any sustainable financing source to cover the increases in demand. That all falls to states. So in this study, as I said, the things what you get when you dial 988 and the implementation strategy that we're focused on are the financing strategies that states are using to fund 988 rollout. So luckily for us in our research, there's tremendous heterogeneity between states in terms of the implementation strategies they are using, ranging from a 988 telecom fee, which is kind of the recommended model. So this is a flat fee on everybody's cell phone bill every month. All of that money goes into a big pot that goes back down to fund the 988 system. This is how the 911 system is financed, to doing absolutely nothing, which are these gray states here. So in this study, again, we're conceptualizing these state financing approaches or lack thereof as implementation strategies being used. And just to kind of show concretely how we put this in an Ames page and kind of fold it into an NIH grant. In aim 1, we do legal mapping and track over time everything that states are doing around 988 financing. Aim 2, we go to the field, we talk to implementers, did a big survey, doing interviews with people involved with 988 implementation, all with an eye towards financing. Again, because we're conceptualizing financing decisions as the implementation strategy. And then we use this kind of natural variation, quasi-experimental designs using diff and diff to tease out the effects of these different state financing approaches, which again, we conceptualize as policy implementation strategies. And we're looking at both effectiveness and implementation outcomes related to 988. All right, so next, policy is as context to understand. So here we just want to understand how policy might be working as a contextual factor. Of course, policy is always mutable, right? We always can change policy. It's never fixed. It can always be changed. You can change the Constitution. It's just hard to do, but you can always change policy. But here we're thinking about it just as a fixed factor, and we want to understand how it might be affecting implementation outcomes that we care about, and also think about how we might select different implementation strategies for different policy contexts. So here is a hypothetical example. So here the evidence-based practice would be suicide safety planning. So an evidence-based intervention, and we want to see it done more often in emergency department settings, right? So we have policy context A, and let's say it is NYU Langone, right? We have an academic center, a private healthcare system, and in this healthcare system, the system has a lot of leeway to do what it wants, and it allows physicians to receive bonus payments for stuff they do. We do a little formative research, and we find that, physicians aren't really motivated to do safety planning. There's a lot of other factors, that a lot of other things they can do, competing demands. Motivation is identified as the barrier, kind of the main implementation challenge. So we say, all right, to address that barrier of low motivation, let's use an implementation strategy that targets motivation, like financial incentives. So we're going to pay every physician or every nurse a little extra money for every safety plan they do with an eligible patient, right? So we think about the policy context and we select an implementation strategy accordingly. Here we have the same implementation goal of increasing rates of suicide safety planning in the ED, but here in this policy context, maybe the VA health system, physicians aren't able to receive bonus payments, yet we still have the same barrier to implementation, low motivation, but we're going to select a different implementation strategy that addresses that same barrier, i.e. motivation, because the policy context is different, right? So like a peer comparison leaderboard or something like that, showing rates of safety planning across different physicians could be another strategy we use that's aligned with that policy context and would work in that context. All right, over here, policy is something to implement. So as I said, here we're really focused on the policy, not the clinical or programmatic evidence-based intervention. And we want to understand how the process of implementing an evidence-supported policy or potentially evidence-supported policy can be improved. Some examples of research aims, we might just want to do descriptive work, understand the extent to which the policy was implemented, how it was implemented, assess knowledge and attitudes about the policy among key groups. We might want to explore enforcement in some way. We want to identify barriers and facilitators to policy implementation, or we could do like what we're doing in this 988 study. We can use quasi-experimental methods to explore the effects of different policy implementation strategies, or we could randomize states to different bundles of hands-on policy implementation strategies. We can't randomize people or places to policy exposures, but when all 50 states are tasked with implementing the same federal policy, we can design a study where we as researchers intervene in half the states with policy implementation supports, not the others, and do a real trial around policy implementation. So just an example again from our work, this was a descriptive R21. Here we were focused on the implementation of state and local policies that earmark tax revenue for mental health services. So we anecdotally observe that more and more states and localities are often opting via referendum and raising their hands and saying, yes, I would like to increase taxes on myself to generate more money for mental health services, because that's something that my community is concerned about. So that's promising, but also, there's a potential that all this money could really not go to evidence-based practices. It could kind of be, squandered on things that don't work so well. So in this study, we just wanted to understand, what's driving decision-making about how these funds are spent and what might we do as kind of external implementation facilitators to help these dollars be spent as impactfully as possible. So just another example to show how we kind of fold this into an aims page and an R21 grant. So again, we start with legal mapping, identifying all the U.S. jurisdictions that have adopted policies that earmark tax revenue for mental health and characterizing the attributes of tax design. And then we go to the field, we talk to people involved with implementation using the EPIS framework or the policy adapted EPIS framework, which Erica talked about, to guide, survey, and interview data collection, and kind of pull it all together within a conceptual framework to inform what we might do in the future to improve policy implementation. All right, I'm going to go pretty quickly here through this last bit. But again, here, policymaker focused dissemination research, the goal is to get better policies on the books. So when we're doing research in this area, we want to understand how we could really change policymakers' minds and alter policymaking processes to increase the adoption and thus reach of good policies from a public health perspective. And we do this, we want to, a lot of this really aligned with communication research. We want to craft better messages and deliver these messages from the right sources in the right mediums. So some example research aims, and I will give some examples as well, but we want to understand our policymaker audience, so their knowledge, attitudes, for support for the policies that we're interested in. Of course, policymakers, I think, it's important to keep in mind that policymakers are people, right? So like things like knowledge, attitudes do matter, but of course, they're not operating in a vacuum. What they do is highly influenced by the broader social and political context. So we do public opinion studies, we analyze news media, entertainment media, social media to understand the policy context related to this health issue that we're focused on in our policymaker-focused dissemination research. And we can do experiments, test different messages, do audience segmentation research, things like that. And of course, a lot of what I've done in this area is really more communication oriented, but there are more hands-on strategies that we can use, such as researcher, policymaker collaboratives, such as initiative out of Penn State called the Research Policy Collaboration, where they do really great work and matchmake researchers and policymakers. All right, so I'm going to go through this quickly in the next 4 minutes or so, give examples of these 3 types of research that we might conduct under this umbrella of policymaker-focused dissemination research. So formative audience research, audience segmentation research, and dissemination effectiveness research. So in formative audience research, we just want to understand knowledge, attitudes, and support, and really predictors of support for a specific policy among a key group of policymakers. So this is an example on a different R21 funded by NIMH. Here are the policies we were focused on were comprehensive state behavioral health parity laws. These laws are recommended by the U.S. Community Preventative Services Task Force. So they kind of had that stamp of evidence based on them. And thus, as we framed it, kind of were ripe for implementation science questions. We did a survey of 475 state legislators, because state legislators are the people who have the ability to really adopt these laws. We assessed support for these laws and then looked at what predicted support for these laws. And we do this from a dissemination perspective to try to identify kind of, mutable targets for dissemination. So as you can see, this belief that parity laws increase access to behavioral health treatments being most strongly and independently associated with strong support for these laws after adjusting for everything that we could think to adjust for. Which means, if we're going to craft a policy brief or even an email or decide what we're going to say in testimony about these laws, perhaps we really want to emphasize this evidence about these laws increasing access to treatments. More and more often, we're thinking about how we can use social media posts from state legislators to understand their knowledge, attitudes, opinions about different issues. It's really hard to get high survey response rates from policymakers, especially elected officials at the state level, but more and more often they're on social media yammering about whatever is going through their minds, and that can give us insights as we use these data that can inform our dissemination activities. Audience segmentation research. So audience segmentation research, the general premise here is if there is a population that you want to influence and persuade and change their mind about something, there's probably heterogeneity in that population in terms of baseline knowledge and attitudes, and probably, tailored messages for different subgroups, different audience segments are going to be more effective than a one-size-fits-all communication approach. So this is an example, again, from our work. I won't get into this in detail, but again, we use data from these 475 state legislators who completed our survey, did a latent class analysis, and tried to figure out, are there different segments of US state legislators who vary in terms of how they think about behavioral health issues broadly? We found these 3 different groups, and I'll just focus on the biggest and most interesting group, this group we call the budget-oriented skeptics with stigma. This group cared the most about finances, about budget issues and return on investment when deciding whether or not they were going to support a behavioral health policy bill that was introduced in their state legislature. This group was really skeptical about the potential effectiveness of mental health and substance use disorder treatments. They didn't really think these treatments could necessarily work. And also, sadly, and probably not surprisingly, this group had the most stigma towards people with mental illness. So then we identify the non-latent predictors of segment membership in this group. So being Republican, being in the South, being male, being younger, all associated. And then we think about, okay, if we're going to craft a message for a legislator with those characteristics, what segment do they have the highest probability of belonging to? Thus, let's craft a message to kind of meet them where they're at to be more persuasive and hopefully more compelling. And lastly, in about 2 minutes, I'm just going to go over really quickly dissemination effectiveness research. So here we're doing randomized controlled trials. We're doing message testing of A versus B versus C and seeing what works best at getting policymakers' attention. Here we look at outcomes like email views, link clicks, requests for consultations, the evidence we disseminate showing up in social media prospectively after we randomize and disseminate. General process, we randomize, we disseminate, we collect our study data. We can manipulate many things in these sorts of studies. We can manipulate the source, right? So we could have the same message, the same policy brief, but states, let's say, are randomized to get that message from an academic researcher, say me at NYU, or an advocacy organization like Mental Health America. And we see which source works best for who. What's most often manipulated in these sorts of studies is the message itself or the frame. Do we use a narrative or do we use quantitative data? If we use quantitative data, do we use economic data, incidence prevalence data, intervention effectiveness data, effect sizes, things like that? We can manipulate the channel, the mode through which the information is delivered. And of course, we always look at effect heterogeneity between audience subgroups in this sort of work, namely Democrats and Republicans, seeing if some messages or some sources work better with some policymakers than others. Just a quick example from our work. This was a cluster randomized controlled trial we did. We were disseminating evidence about adverse childhood experiences and child maltreatment being risk factors for behavioral health issues in adolescence and adulthood. And here we wanted to figure out was, how much does including state-tailored economic evidence in dissemination materials matter? And how much does the state tailoring aspect, right? So tailoring the data for the state of the legislator. So a New York legislator, if randomized to get the tailored data, would get New York state level data about the issue. How much does that matter compared to just providing national level data? We did this trial. We found that our main hypothesis was true for email views, but then when we stratified our data by political party affiliation, we found that our effect was entirely driven by Democrats. What we did had no effect whatsoever among Republicans, which is good information to know, right? I would gander that, maybe the source mattered a lot. All of these messages were coming from an academic researcher. Perhaps we are less appealing to Republicans. Thus, perhaps we should consider manipulating the messenger when communicating this evidence to Republican legislators. So I will stop there. We just got a puppy, so I'm going to indulge in the shameless, cute picture, which I don't normally do, but I'm going to do it for a while. There's Penny Girl, sound asleep. And yeah, I'll stop there. Thanks for listening.
Thanks so much, Jonathan. And thanks so much to all of our wonderful panelists. Those were super informative presentations. So before we open up to the audience for a question and answer period, although everyone is welcome to start sort of putting your questions in the Q&A, just as a kind of logistical point, just know that we are recording the video. And so if you don't want to use the raise the hand function and appear on YouTube, I'm happy to read out your questions. So feel free to put them in the chat or Q&A. I know the new Zoom feature is a little wonky. I'm going to just go ahead and, I can't help but think about the present. So I kind of appreciate, Erica, you sort of like naming that. And I was just thinking about like uncertainty of policies and, especially when they face litigation. But, Erica, you mentioned that you also study policies of limited duration. So kind of Medicaid waivers. And, there have been lots of policies like opioid settlement funds that sort of have limited duration. So I guess I'm curious, like, how you all think about both uncertainty, but sort of how temporality like shapes implementation, just like especially in the current moment, like not knowing whether a policy actually will be implemented, like how does that how does that shape a policymaker? Yeah.
And so often one of the things that we do in policy implementation research, like both in conceptualizing, but also like, you know, analytically sometimes, is try to understand what the different phases are and, you know, stratify analysis essentially. Like, are there different things happening in different phases? Does implementation change? Does outcome change? And those phases, like, sometimes might include a pre-implementation phase, as Erica is alluding to, which is so important. Like in the quantitative world, we'll often use terminology about like anticipatory effects for that, where actually the policy isn't on the books yet, but in the year before the policy gets on the books, when it's like hotly debated, you might see people start to sort of anticipate adherence with that policy, even though they don't have to yet. Which is also the second point I'll make is, I think, related to this phenomenon in policy, which the economists call policy endogeneity, which is that like policies are responses typically. Like you could imagine a perhaps better world where our policies are super proactive and designed to like prevent future problems, but usually they are reactive responses to problems that are bubbling up in a jurisdiction. And they also can take a little while to actually get on the books. And so there's this like correlation problem where the outcomes that the policies are designed to impact are also what's causing policymakers to try to get that policy on the books in the first place, which like relates to this whole idea of even when it's not on the books, the policy could sort of be relevant to what's happening.
I don't think I have anything to add to those two wonderful points, but I have things to say to the question in the Q&A. I'm happy to speak to that. Mary has a question about it being hard to contact policymakers. Indeed. So they're actually pretty easy to contact. It's hard to get them to reply. It is the thing. But so I guess we've dealt with this in a few ways. So I'm going to talk briefly about elected officials and then kind of administrative policymakers, two groups, and they're kind of different when it comes to this stuff. So state legislators, we've done a lot of work on. They're really important because they make really important decisions about things they often know very little about because they're just like normal people who get into politics. So state legislators, we did this survey back in 2017. We had a grant, we paid a survey research firm a whole bunch of money to do this really resource intensive recruitment approach. And we got a response rate of like 17%. This was back in 2017. If we spent that much money today, I think we get a response rate of like 4%. This has gone way downhill. So I don't hold out a ton of hope for surveying state legislators to get a representative sample. What we more often do now is, it's easy to get their contact information. You can scrape it, but really you can buy these contact databases. And for a couple grand, you can get an Excel sheet with all of their email addresses and a bunch of information. You can randomize, disseminate, and then observe, right? Do they view the email? Do they click the link? Do they take you up on your request for an educational meeting about it, right? And you can do these experiments and you don't have to rely on surveys at all whatsoever. So I think that can tell you something from state legislators. With administrative policymakers, we build these contact databases. So often across states, like the professional titles of the people involved in similar implementation activities vary a lot. So often it's kind of like this detective work of going to state websites, reviewing meeting minutes, doing the backwards formula thing to figure out people's email addresses after you know their names, and like building these contact databases of 600 administrative policymakers and implementers across the US, and then sending them a survey. There we get decent response rates, decent being like 30% if we follow up enough and the issue is aligned with something that they care about. And we offer incentives, some take them, some don't. But the administrative policymakers, I still think there's hope to get like primary data from a decent size sample. With state legislators, much less so. You can survey all state legislators. I think it makes sense if you're doing like a survey-based experiment, right? Because then even if you get a low response rate, at least you have internal validity because of the experimental design where you show them a policy brief and then they answer questions. But then, you know, external validity and generalizability is always questionable, but at least you know about respondents and non-respondents because with state legislators, a good bit about these folks is publicly available on the internet.
A strategy that I use mostly, I think, for qualitative research, but it could also be relevant in the context Jonathan is talking about in terms of, you know, connecting with sort of larger samples of policy implementers, is like partnerships with intermediary organizations. There is just no way that at least I personally, maybe some of you can, like, I can't like forge individual relationships with all of these policymakers. It's not totally my skill set, frankly. And, you know, we all just have like limited time and bandwidth. So partnering with like professional societies or advocacy organizations or foundations that have really established networks with policymakers can work very well. Like I'm currently doing a lot of work with the National Association of Medicaid Directors, which is exactly what it sounds like. It's the professional organization for all of the Medicaid directors and other leaders within state Medicaid programs. And like, it's so helpful in that their leadership is like, oh, you're interested in states that are doing innovative things in like pediatrics payment policy. Let me introduce you to like these 3 people, right? And so it both saves time and is like a trusted connector. So I think that those are among my most like treasured partnerships, is those intermediary kinds of groups.
And I'll just add very quickly, I second what Beth says, and kind of our new standard approach is we create our own contact database, we send out our survey so the denominator is known and we can calculate a response rate. And then after that recruitment period with these partners, because normally they'll send it out, but they'll send out like one link and they'll blast it out, right? So it's like this convenient sample, response rate unknown, just suboptimal. But now we do both, right? And then we can compare those 2 data sets and you're getting more perspective, which is a good thing. But those organizations are key in doing that. They're like, yeah, we'll put it in our newsletter and blast it out. Sure.
I'm noticing that we have one question, but we have 3 minutes left in this. And this one question is quite big, which is sort of how the current political climate changes the way you all approach your research. So I'm going to sort of like allow you all to look into Dr. McGinty, Grable, and Purtle's work moving forward as a way to see sort of how the political climate is shaping everything. But I just want to thank our wonderful panelists for an amazing overview of policy dissemination, implementation, science, and virtual round of applause.